Good morning, everyone. You're very welcome to the HSE National Clinical Programme for Diabetes documents launch. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you're using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to Professor Derek O'Keefe, National Clinical Lead for Diabetes. Thank you.
Hello and good morning, and a very big welcome to our launch of multiple documents from the National Clinical Programme of Diabetes. I want to just take a moment to thank the hard work of many collaborators across the National Clinical Programme team and the wider diabetes working group that has enabled this to happen. So clinicians, patients, patient advocate groups, and policymakers coming together to produce these documents that you'll see today. In particular, I'd like to thank the Minister for attending today and his support of many of our diabetes measures, such as the Diabetes CGM programme, the Diabetes Registry, and the Diabetes Strategy. I would also like to welcome and introduce the National Clinical Advisor Group Lead, Dr. Sarah O'Brien.
Thanks, Derek. Good morning, everyone, and many thanks to you all for attending the launch today. As Derek says, we have a number of key documents that we'd like to share with you that have been developed by the National Clinical Programme for Diabetes in partnership with many stakeholders. To start with, the development and publication of the Diabetes and Pregnancy Model of Care is a very welcome document that describes the end-to-end pathway for individuals who are living with diabetes before and/or during pregnancy, and sets out what an individual and their identified supports can expect from their healthcare services before, during, and after pregnancy. This pathway places a clear emphasis on prevention of illness and complications and supporting individuals to live well with diabetes. An important component of this model is the expansion of the very successful structured chronic disease management program in general practice. Any individual gestational diabetes diagnosed since January 2023 will now be eligible for enrolment on the prevention program in general practice, which allows the participant 2 free visits per year, one each with their practice nurse and GP for history, physical exam, blood tests, and the development of a joint care plan to agree an approach to tackling the patient's risk factors for diabetes and supporting the patient to self-manage their risk factors through, for example, referral to particular services such as the diabetes prevention program. The Diabetes Prevention Programme is off in the chronic disease hubs in the community as funded as part of the Enhanced Community Care Programme. The Diabetes Prevention Programme Evaluation Report is also being launched today, which shows really positive impacts in terms of participant satisfaction with the course, as well as improved health outcomes at 12 months post completion of the course, which indicates positive behavioural changes and reductions in risk factors for diabetes for participants. The Discover Diabetes Programme is a programme offered to all newly diagnosed all patients who receive a new diagnosis of type 2 diabetes. Again, it's offered in the chronic disease hubs in the community. And this programme aims to empower patients with the knowledge and tools to manage their diagnosis, to reduce their risks of complications, and to live well with their condition. Again, this programme is demonstrating significant improvements in patient risk factors for disease progression and complications, as well as demonstrating a high level of participant satisfaction. For individuals living with diabetes before, during, and after pregnancy, there will be a need for acute specialist input, but the focus will always be on delivering person-centred care at the lowest level of complexity, in line with the Sludge Care vision. I'd like to thank all of those who have led the delivery of the documents being launched today. A particular thank you to Professor Derek O'Keefe, Dervla Kennedy, Lisa Devine, Joanne Lowe, Margaret Humphreys, Liz Kirby, Kathy Breen, and Karen Harrington, who provide essential clinical leadership day in, day out to the National Clinical Programme of Diabetes to support the delivery of improved care and improved outcomes for patients living with diabetes. A big thank you also to Professor Sean Deneen, who so ably led the clinical programme Diabetes for a number of years prior to Derek, and has supported the delivery of the Transition of Care survey report, which will also be discussed today. Also, a sincere word of thanks today to Professors Fidelma Dunn and Mary Higgins, who gave so much of their time to lead the model of care through to publication. All documents being presented today have had a significant input from a wide variety of stakeholders. So to all those who have contributed, a big thank you. And as the clinical programme now turns its hand to supporting the implementation of the model of care, I hope we can continue to rely on your support in driving improved services and improved outcomes for individuals living with diabetes. And following the launch today, all documents will be freely available on the ECC Hub on HSE Land and the National Clinical Programme Diabetes website, and we'll share the details of those websites with you later. So thanks again. I hope you enjoyed the launch today. I'm going to hand back to Derek. Thank you.
Thank you very much, Dr. O'Brien, for that great oversight of the work that the NCAGL does, and in particular the NCAGL for the National Clinical Programme, rather, for diabetes, which is a truly collaborative effort. I'd like to introduce now the Minister of Health, Minister Donnelly. I'd like to welcome the Minister to this launch of our National Clinical Programme Diabetes documents, and once again thank him for his support of many things across the diabetes landscape, including the Diabetes Registry and the Diabetes Strategy with his team in the Department of Health. Minister, welcome this morning.
Minister, at the moment we are unable to hear and see you. So Professor O'Keefe, I'll just ask you to stay on the screen just for a moment. Minister, if you want to try, and you unmuted and we have your camera connected. Maybe if you wish to leave and come back in again, and we may move on to the next person, and hopefully we can get you back with us. That would be great. Excellent. So Professor Jerry, would it be okay if we moved on to the next people, and then we could come back if the Minister gets to log in?
Yes, of course, no problem. Yeah, so I'm delighted to introduce Professor Mary Higgins and Professor Fidelma Dunn, who led the model of care for diabetes and pregnancy. So I'd like to hand over to Professor Mary Higgins.
Good morning, everybody. It is indeed a pleasure today to, first of all, have to be able to upload slides and unmute and put on a video at the same time, but also to be here finally to present our model of care, which, as Professor O'Keefe said, is a massively collaborative effort and one that we're very proud to present today. I'm presenting with Professor Fidelma Dunn, who is an endocrinologist, and I work as an obstetrician and maternal medicine specialist. So today we're going to talk about the development and progress of the National Working Group to develop this diabetes and pregnancy model of care. We're going to talk about her findings, key recommendations, and next steps and implementation. So this model of care is very much aligned with national programs, including the National Maternity Strategy from 2016 to 2026. It's currently in action with the Healthy Weight in Children HSE Action Plan from 21 to 23, and the integrated programme in the prevention and management of chronic disease. It is truly, as I said, a collaborative effort. We very much, anyone who works with diabetes is aware, it is not only multidisciplinary, but interprofessional, where every member of the team is presenting a crucial role, and in the centre is the person with diabetes. And not only did we have people from multiple different professions and advocates and people living with diabetes, we also had people working in different scenarios from community up to maternity level care, so that we can truly say this is a national document. What we did as part of the working group, well, we talked about model of care development and overview of our current services in Ireland, pre-pregnancy care, of course, planning for pregnancy, ideally that women will be, and transgender people will be in the best possible condition when they choose to become pregnant. Pre-gestational diabetes, which of course includes not just type 1 and type 2, but genetic diseases, MODY, CF-related diabetes, because we have more women with cystic fibrosis who are becoming pregnant, and transplant-related diabetes. We also talked, of course, about gestational diabetes, which is a risk factor for future type 2 diabetes. We reviewed and debate vigorously about the working document of the model of care, provided new recommendations. And we would like to note, while there was delays in production document due to the pandemic, the cyber attack, at one point with no project manager, we're very happy to present it today. I'm now going to hand over to Professor Fidelma Dunn, and I'll move her slides for her.
Thank you, Professor Higgins, and welcome everybody. I will continue with the model of care now. So for anybody working in this area, we know that diabetes in pregnancy is the most common metabolic condition that is encountered in pregnancy. And overall, about 1 in 6 pregnancies are affected by diabetes. The impact of diabetes is enormous for the mother and infant, both in the index pregnancy and for their long-term health. So services addressing diabetes in pregnancy, unfortunately, have not changed very much over the last 20 years, despite the increase in the numbers of patients that we see, the complexity of cases that we see, and the complexity of the process of delivering care and the tools that we have now to deliver top care. We know that these pregnancies are affected by conditions like preeclampsia, macrosomia, more cesarean delivery, congenital malformations in infants, and increased perinatal mortality when you compare these women with diabetes against the background population who do not have diabetes. And many of these things can be improved and brought down close to the background population rates with good delivery of care and good practice of care, including pre-pregnancy care. Now, children born to mothers, as well as having the problems that they encounter at delivery, also have an increased lifetime risk of type 2 diabetes, especially for babies who are born at the extremes of size, so very small babies and very large babies. They also have an increased risk of obesity, and of course, obesity is such a big problem for us in the country now. Anything that we can do to reduce this is important. And there's a body of knowledge now emerging of the association between metabolic conditions, including diabetes, and neurocognitive dysfunction like autism spectrum disorders and attention deficit and hyperactivity disorders. So these are all new things that have evolved in the last decade or 15 years, and we really need to address these in the way we deliver and what we do for these women during pregnancy. In addition, mothers with pre-gestational diabetes may experience worsening of their diabetes complications during pregnancy, in particular retinopathy and nephropathy, and these have to be really considered a lot during the delivery of care to the women. Now, women who experience gestational diabetes have a high lifetime risk of developing type 2 diabetes, and that's as high as 50% in the 10 years following the index pregnancy. In addition, they have a high rate of cardiovascular disease independent of the development of diabetes. Next slide, please. Next slide, Mary. Thank you. So in the implementation of the model of care, we debated how this should be and came up with the hub and spoke model as being the best way to deliver care for this group of women. So we have 6 hub hospitals, and each hub hospital is then helping to deliver care in the spoke hospitals. So this system is already established and works very well and can be strengthened further so that the flow of patients from the hub hospitals to the spoke hospitals can be done seamlessly. To implement the model of care, we know that it will require additional resources because it is going to be resource dependent. Now, in developing the model of care, we examined all areas of delivery of care in the HSE, and we feel in the delivery of this model of care that all areas can be utilized. So, for example, at level 0, an example of a service that could be delivered to these women who are either in the pre-pregnancy stage or in the pregnancy stage is that every time you meet these women, you should reiterate the same principles, the same basic messages, and that ensures that every contact counts. When we go into general practice has a very important role in pregnancy planning and contraception. And then through the maternity and infant care scheme, it can have scheduled reviews of the ladies. It has a key role to play in identifying cases of diabetes through case finding prior to pregnancy, and then the important step of postnatal follow-up, especially for women with GDM. In the community specialist ambulatory care hubs, focus should be put on diabetes prevention. And then in the special ambulatory care hubs, this is where the diabetes and obstetric teams manage the patients jointly. This is where we deliver things like Daphne for type 1 patients, and where we see the complicated type 2 patients. And then a small portion is the specialist inpatient care, which is all about the delivery of good labour care and birth care for these women. Next slide, please. So the document is very detailed, and when you go through it, it will take you nicely through the stages of how you deliver a process of care for these women. But essentially, we want this process of care to be person-centered, to be individualized, and to be available wherever the woman is in the country. Pregnancy in women, as I've said, with pre-gestational diabetes and gestational diabetes remains high risk, and therefore we recommend that these women follow the specialized care pathway. The care pathways in the document are outlined clearly for women with pre-gestational diabetes and gestational diabetes, and it's important that the people involved in the care of these women become familiar with these pathways. The role of the multi-professional team is really important. So our advanced midwifery and nursing practitioners and our clinical midwifery specialists and clinical nurse specialists, they are really a vital part of this delivery of care and can be involved in all areas, including audit and research. There is a big move towards encouraging more breastfeeding because we know that this is important for the health of the mother and for the infant. So this should be encouraged antenatally, and we should have the right people with these women to make sure that breastfeeding is successful. And as we all know in this field, the use of technology has exploded over the last number of years. There is excellent evidence that technology use in pregnancy for women with diabetes is both clinically effective and cost effective. And members of the multidisciplinary team, regardless of their location, need to be upskilled and be familiar with all of these technologies. Next, please. We understand that all hub and spoke hospitals will require additional resources to implement this model of care, and we are all willing to work in the bigger group to ensure that this happens. As I said, it's imperative that staff have specialized training in diabetes and pregnancy because it's a very challenging area. We are recommending universal screening for gestational diabetes, and we're delighted that the Minister already has endorsed postnatal routine testing for women with gestational diabetes in the primary care setting. He's examining and looking at how to operationalize test strips for all pregnant women with gestational diabetes, and he has ensured that there is now a specialist path for diabetic retinal screening for women with gestational diabetes, which has really improved this area of care for these women around the country, and we thank you for that. Next slide. As of November 2023, women with gestational diabetes can now be seen as part of the chronic disease management program. As I said, in the background, operationalization of the funding provided for the provision of test strips for women with GDM is happening. We have written and sent an application to the National Screening Advisory Committee to examine universal screening for GDM. Bids have been made for additional staffing for acute DIP care and maternity services, and we continue to advocate for resourcing and implementation of the model of care. The diabetic retinal screening program for these women in pregnancy is now part of the national screening program, and we are beginning now to look at the updating of clinical guidelines, which will complement the model of care and work with the National Women and Infants Program on this behalf. Next slide. So I would like to take this opportunity on behalf of my co-chair, Professor Mary Higgins, and the entire team, and recommend this model of care to you. And we look forward over the next decade to examining how this model of care can improve outcomes for women with diabetes in pregnancy and their infants. Thank you very much.
Thank you very much, Professor Dunn, and to your colleague, Professor Mary Higgins, and indeed the entire collaborative group that you assembled and produced this wonderful document for the model of care of people with diabetes and pregnancy. So I would now like to welcome the Minister of Health and thank him, as you mentioned, for the support he's given so far for the diabetes ecosystem, both in diabetes and pregnancy, and his commitment for a diabetes registry and indeed a diabetes strategy with his colleagues in the Department of Health. So Minister, welcome this morning to over 450 delegates on this webinar where we're launching these documents from our clinical program. Welcome.
Minister, the sound does not seem to be working. So I'm just going to get you to check and see if where it says mute, there's a little up arrow beside it. And if you can, yeah, we can hear you now, Minister. Thank you very kindly.
Perfect. Thank you very much. Listen, thanks very much for the opportunity to speak briefly to people this morning. I really am delighted to be here. I'd like to say just a few words of thanks to begin. Can I say a really big thank you to the whole team of the National Clinical Programme for all the work done. The documents that are being launched today, they're very, very useful for patients and for our healthcare professionals. And I know from past experience of seeing how these documents are developed, there's a vast amount of work and care and attention and detail goes into them. So thank you to everyone who's been involved in getting us to where we are today. It's an important day and it has come on the back of an awful lot of work. Thank you very much. Can I say thanks both to Professor Dunn and to Professor Higgins and to the patient rep, Valerie Humphreys, for all your work on the diabetes pregnancy model of care. Again, something we've been really looking forward to seeing launched, and it's great to see not just that it's been launched, but that it has been so well thought through, so well designed. It's very reassuring, and thank you for that as well. And I'm not sure if Diabetes Ireland are on the webinar today. I didn't see that in the note, but in case you are, I hope you are, but I'm not sure. But I really want to just reference Diabetes Ireland. I had a very useful engagement with them through the chair of the All-Party Diabetes Committee, Deputy Cormac Devlin. We met here in the Department of Health and went through a lot of the measures that patients were looking for in particular, and we've managed to act on them partly through what we're launching today. And I want to thank Diabetes Ireland for your ongoing work. It's greatly appreciated. There are 5 or 6 areas I think are worth mentioning in terms of new services that are in place and more services that are coming. The first is the Chronic Disease Management Programme. We launched it about 3 years ago. Diabetes is one of 4 chronic diseases. We have new research showing that over 90% of patients involved in the program, including with diabetes, are now successfully managing their condition at home and in the community setting in a way that wouldn't have been possible previously, with access to specialist nursing, specialist medical care, and technologies. GPs been given more supports as well. The GPs have done a fantastic job. It's very, very encouraging to see. So we now, for GMS patients, any with type 2 diabetes, have a very well-supported plan. The 4 planned appointments with the GP or the GP nurse per year to monitor the condition on an ongoing basis. And then if specialist care is required, there are chronic disease management hubs, specialist nursing and medical staff and health and social care professional staff available. Yeah, it's going really well. I think one of the questions we have to ask ourselves now in terms of eligibility is that's great for all of those who have a medical card, but what about everybody else? So we want to look at what we can do, because ultimately our aim is very clear. Our aim in government is very clear, which is to make sure that anybody who's living with diabetes, type 1, type 2 diabetes, has timely access to the healthcare supports and the community supports that you need to manage the condition, live the best life you can live, with that care directed in the first instance to support people at home, in the second instance then their community, be it with the GP or into one of the chronic disease management hubs, and then as a last resort obviously into the hospitals. And really our aim is to make sure that there is affordable and timely access for everyone who's living with diabetes, and that's the journey we're on. One of the second thing then is the diabetes registry. This was raised with me directly by Diabetes Ireland, and so in the budget for last year I allocated funding to implement a number of initiatives around diabetes care, including getting going on the diabetes register. And even though new development funding was very tight for the budget this year, I'm sure many of you will have seen the coverage. We were fighting hard to get new development funding. In spite of it being tight, I was very insistent that we protect the money to move on and get that register set up this year for the reasons that you all understand very, very well. The other thing I did was I asked the Chief Medical Officer to kick off a review of our diabetes services to really understand what's working well, where the gaps are, where we have geographic variance. Some of the hospitals are doing very well. Some of them may not have the same level of services that are required. So that work is ongoing now. My department is working with the HSC on that. They'll be bringing a report back to me in terms of recommendations. We may wrap that into a diabetes strategy. It may be simpler than that. It may be a reasonably small number of actions that we can just crack on with. But critically, what we want is a national strategic view in terms of the model of care. And I want to thank, I know there's officials from my department at the webinar this morning, and obviously we've got our HSE experts as well. So it's great to see that work is progressing. I think that work will form the basis then of funding asks through 2025 and further. When we have a diabetes strategy, it's easier to frame the asks in terms of new development funding. It's what we do for maternity care, for cancer care, for palliative care, for mental health, for lots of different clinical areas. And I think we should aspire to be doing exactly the same to support those with living with diabetes. The next area then, which we're covering today, is gestational diabetes. Again, this was a core ask of Diabetes Ireland, that we would put in place within chronic disease management, that we would have screening available, and that's a service in terms of access to screening now. It's very new. My understanding is we launched it in November, so it's only up and running about 3 months. I've met with some of the healthcare professionals providing that in our primary care centres, and it's great to see that level of screening coming in now for gestational diabetes or preeclampsia. And similarly, of course, we have now this wonderful new model of care that's been launched for diabetes and pregnancy, which the screening, I guess, really is a part of that wider model of care, and it's fantastic to see that. As I hope you're aware, you may not be aware, but as I hope you're aware, I was very keen that women's healthcare took a leading part of this government's term. What I asked for was, I said, look, we have years and decades to catch up on, and we need not just to catch up. We need to have a very clear ambition that Ireland should be one of the leading countries in the world in terms of women's healthcare. Part of that has been the investment in maternity care, fertility, endometriosis, menopause, see and treat gynae clinics. I opened our 16th one of them in Sligo University Hospital just a few days ago. They've reduced the waiting list for gynecology referral, so typically from the GP into a gynecologist. The waiting list was 4 years, which is entirely unacceptable. Their waiting list is now 4 weeks. We've gone from 4 years to 4 weeks. That's the kind of ambition we have to have for diabetes access to care as well, the kind of success we're seeing. And as part of that push for modern, effective, timely access to women's healthcare services, I'm delighted. I'm so happy to see the model of care being launched today, and the gestational diabetes screening as well. It's fantastic to see. And then finally, the access to blood glucose testing strips. It's a modest enough proposal, but again, I think it's an important one. So we made initial funding available last year in 2023 to make the strips available to women without charge with gestational diabetes. That's like 4,500 women annually. So it's a good start. It's a modest measure, but it's a good start. And then we're looking at expanding that. So the HSE are working now on the question of how do we make the glucose strips available just anywhere where they're required. So look, that's it. That's a quick run through. I know that the healthcare professionals on the call are doing an awful lot more. There's a vast amount of work going on, and I just wanted to end where I started by acknowledging the huge work, the passion, the dedication, the expertise, the long hours coming from the patient side, coming from officials in my department, coming from our healthcare professionals in diabetes services right across the country, right across the HSE. I have the easy job, which is just to try and fight to get you guys money and resources. You guys have to do all the difficult stuff, all the clever stuff, which is to make sure that we have the best possible services. And ultimately, that must always be our ambition. We must always aspire to, in the coming years, being seen as one of the leading countries in the world in terms of prevention and support and multi-layered healthcare supports for anyone in the Republic who's living with diabetes. So thanks a million, and thanks for the opportunity to speak this morning.
Thank you very much, Minister. We appreciate your wise words on the diabetes landscape and indeed its future. And just to reassure you that, yeah, it's a very collaborative approach. We've been clinicians, Diabetes Ireland, and indeed the policy makers, as you mentioned. Cormac Devlin's done a great job chairing that cross-parliamentary group that we're a member of. So it's kind of like a shamrock with patient advocates as one, the policy makers in the middle, and then the clinicians on the other side, with the stem being the patients of the shamrock. So it really is a collaborative approach which has produced these great documents. So thank you for your support, and we'll be in contact again for ongoing support. Thank you. So I'd like to introduce now Ms. Ciara Coveney, the advanced midwife practitioner, to speak about the role of the midwife in the diabetes in pregnancy. Thank you.
Thank you, Professor O'Keefe. Thank you for the opportunity to speak today about the role of the midwife for the model of care diabetes in pregnancy being launched today. As a member of the Model of Care Working Group, I'd like to acknowledge firstly the huge amount of work that went into the development of this document from a diverse array of disciplines to ensure that we deliver the best evidence-based and outcome-focused care for women and their babies. To assist me with my presentation, I have one slide, which at a glance gives you a visual representation of the role of the midwife in diabetes in pregnancy. And I have split it into 4 themes: care, continuity, collaboration, and convenience. So from a care perspective, according to the model of care, women with diabetes in pregnancy will be provided with care in the specialist care pathway for high-risk mothers and infants as outlined in the National Maternity Strategy. Central to the philosophy of midwifery is that regardless of risk stratification, all women will benefit from the care of a midwife. The ethos of midwifery is to work in partnership with women, to guide them with the best evidence-based practice and provide choice to each woman in her individual pregnancy experience. Registered midwives provide care to women with gestational diabetes and pre-gestational diabetes before, during, and after their pregnancy, working within the multidisciplinary team with adherence to local and national policies and guidelines. This includes care related to preconceptual care, promoting self-care and emotional well-being, blood glucose and ketone monitoring, and oral and injectable therapies. Midwives, student midwives, inclusive of staff midwives, clinical midwife managers, clinical midwife specialists, and advanced midwife practitioners, have the ability to positively influence improved maternal and neonatal outcomes for women with diabetes, and this is through the high quality care that they provide. This is evident from international studies and more recently from my own research conducted in the National Maternity Hospital, comparing maternal and neonatal outcomes following the implementation of advanced practice-led virtual clinics. Moving on to the theme of continuity. Midwifery continuity of care is central to providing comprehensive clinical care for diabetes in pregnancy. Clinical care provided by a known team of healthcare professionals in a single location was one theme identified by women in the model of care as being important to them. A substantial body of evidence exists showing that integrated care and continuity of care and carer contributes to high quality and safe care and to maternal satisfaction. This model of care has highlighted future midwifery staffing requirements, and it is important that midwifery staffing levels for diabetes in pregnancy are appropriately resourced in order to continue this midwifery-led care for those women attending these services into the future. So the next theme is collaboration, and this comes in two different forms. The first is collaborating with women. So pregnancy complicated by diabetes in pregnancy escalates women into the specialist high-risk care pathway. It is important to collaborate with women so that we're able to facilitate both maternal choice and individualized care plans in line with clinical safety, best evidence-based practice, and clinical needs. The second part is within the multidisciplinary team. So this model of care outlines a multidisciplinary approach from a wide range of clinical specialties, and it's essential to respond with this to the dynamic needs of women with diabetes in pregnancy. The midwife is often the central contact for women and the wider multidisciplinary team, and this enables women to navigate hospital and community systems and processes, which can often be quite complex, but are becoming less so thanks to the ongoing work of the Diabetes National Care Programme. The model of care recommends that a registered advanced midwife practitioner is practicing in each hospital group network. This is in line with international evidence that demonstrates that advanced midwife practitioners, through advanced clinical decision-making, leadership, and autonomous practice, have delivered faster access to care, improved clinical outcomes, and strengthened service development nationally. Lastly, in relation to our convenience theme, women with diabetes in pregnancy will often attend multiple appointments throughout their pregnancy, and often more than the general pregnant population will. The use of healthcare technology, particularly diabetes technology, can present an opportunity to provide hybrid care and provide some of those cares done closer to home in line with Sláinte Care recommendations. The establishment of midwifery virtual clinics has enabled a reduction of physical visits for women to the hospital. Clinical midwife specialists and advanced midwife practitioners are also tasked with navigating the ever-evolving world of diabetes technology, from continuous subcutaneous insulin pumps, hybrid closed-loop systems, and continuous glucose monitors. Nationally, midwives have risen to this challenge through continuous professional development, but we do acknowledge that there is still work to do. This model of care provides a framework to allow technology to be facilitated equally throughout each geographical region. In conclusion, we are delighted to be here today to see this model of care for diabetes in pregnancy launched. As a profession, midwives are looking forward to working together with women and our interdisciplinary colleagues to shape the future of diabetes and pregnancy care in Ireland.
Thank you very much, Ms. Kerry Copney. Great oversight of the important role of the AMP in diabetes and pregnancy. I'd like to introduce you now to Dr. Lisa Devine, who is our ICGP lead on the National Clinical Programme, who will speak about sick day rules for people with diabetes.
Hi everyone, and thanks very much to Professor Derek O'Keefe for the introduction. I'm really delighted to be here, and we're going to change gears just slightly, and I'm going to talk about some of the other documents which are being launched. Now, these documents, we speak about them, we might call them our sick day rules documents in some ways, or I suppose these are documents which have been created to help people living with diabetes, their families, carers, and the healthcare professionals that work with them to manage their diabetes during an acute illness. On the screen here, you can see our three documents. The first, which is aimed at people living with type 1 diabetes. The second document is aimed at people living with type 2 diabetes. And then the third document is aimed at healthcare professionals who work along with people living with diabetes. Now, these documents are really important and timely. We know that people living with diabetes carry a higher risk of complications during acute illness than those without. However, good advice on elements such as glucose testing and control, hydration, calorie intake, fluid intake, and when to seek medical attention can make all the difference in terms of aiding a speedy recovery and avoiding a hospitalisation. I'd like to bring these documents a little bit to light and see how we might use them in everyday practice by introducing you to John, who is a gentleman with type 2 diabetes and the kind of gentleman that we might meet in our everyday practice. I think everybody probably knows a John. John is a 74-year-old gentleman and he has had type 2 diabetes for 12 years. He had a previous mini stroke, a TIA, but apart from that, he doesn't have any complications from his diabetes. He does have high blood pressure and high cholesterol, and importantly, he's on a number of relevant medications. So he's on some metformin for his diabetes, he's on a drug called an SGLT2 inhibitor, he's on some ramipril, a statin for his cholesterol, and he's on a little bit of aspirin as well after his TIA. Now, John's daughter, Anna, has contacted the surgery this morning because she's worried about her dad, and her dad has been unwell for about 10 days. Initially just with a minor illness, and in the last 5 days he's developed a nasty cough and a fever, and in the last 24 hours he's mostly been in bed. She's also able to tell you that he is alert and talkative and can get out to go to the bathroom. She says he's been taking all of his medications. He is a bit nauseous, so he hasn't taken much else in terms of food or fluid, and she's not just sure if he's been passing more urine or if he's more thirsty than normal. Based on this information, John comes in to see a GP that day, and thankfully the GP that he sees has got access to all of our new documents. She notes that John is alert and well, but he's coughing. She is confident in being able to look out for red flag symptoms for John in the context of his acute illness and history of type 2 diabetes, and she takes his blood pressure, pulse, and oxygen levels, which are all normal. She does note that he has a temperature and he has signs of a chest infection. She correctly takes his capillary blood glucose, which we're happy with, at 7 millimoles per mole, and he doesn't have any ketones. She now feels confident in making a diagnosis of a lower respiratory tract infection, a chest infection, and is able to recommend an appropriate course of antibiotics. And in addition to this, pressing pause on some of John's medications for 2 to 3 days until he's feeling better. And this is because he's not able to take in much orally. So she asks him to stop taking his metformin, his SGLT2 inhibitor, and his ramipril just for 2 to 3 days until he feels better. She also feels it's a great opportunity to signpost John to the new document aimed at people living with type 2 diabetes on managing their type 2 diabetes during an illness. And John is really interested in this. A small whistle-stop tour of some of these documents shows some of the key topics that are covered, including symptom recognition, so what to watch out for if a person living with diabetes is unwell, and those red flag symptoms that would prompt someone to seek medical attention. Really practical information on how to manage food and fluid intake, when to check the blood sugars, and then really key information on medication safety. In some patients, it's necessary to press pause on some of their medications for 2 to 3 days until they're feeling a little bit better. And crucially, these documents also provide information on what to do with insulin, which should not be stopped during an acute illness and may need to be altered. Overall, John and his GP really benefited from access to these new documents during the consultation, and I personally am really looking forward to using them in my consultations in the next few months. I'd like to recognise the huge amount of work that went into the production of these documents, and it really was a massive collaboration. I have got a picture of the 3 of them on screen there, and also we'll post the link to the documents in the chat, and you can see the link to the documents just down below. So again, thank you very much for inviting me to speak briefly today, and I'll pass you back to Professor O'Keefe.
Thank you very much, Dr. Devine. Really important sick day advice for people with diabetes. I'd like to hand you over now to Ms. Joanne Lowe, our nursing lead on the National Clinical Programme, who will speak to us about insulin titration.
Joanne, if you just want to unmute yourself, please.
There we go. Can you hear me?
We can indeed.
That's great. Thank you very much. I'd just like to speak briefly about a very important document, which is the National Insulin Titration Guidelines. This is primarily for nurses and midwives who are non-prescribers of medicinal products, but working in the specialist area of diabetes care. This document is a revision of an original document which was published in 2016. Since 2016, lots of things have changed in the area of diabetes, as we've been hearing about, and the update includes changes in therapies. That's both the types of insulins that we use, and for the first time as well, we've included continual glucose monitoring. But also as well, and in keeping with what we've been talking about this morning, the importance of women's health, there is a new section in this document which is providing guidance for those who are working in the high-risk maternity setting. This document can be found on the National Clinical Programme's web pages, and we'll be able to share the link with you there. So as I say, very important for anybody who's involved in insulin titration. And that's all I have to say. I'm a quick talk with a signpost to that document. Thank you.
Thanks very much, Joanne. That's a really insightful oversight of the documentation. And again, I should mention that all these documents are available on the National Clinical Programme website. I'm delighted now to introduce Ms. Valerie Humphreys, a person with diabetes who's been a significant contributor and collaborator on a lot of the documents today. So Valerie, I invite you to speak.
Hello, I'm delighted to have the opportunity today to speak to you all, whether you're a person living with type 1 or type 2 diabetes, a healthcare professional, or just an interested bystander. I live with type 2 diabetes, and I'm the type 2 rep on the National Clinical Programme Working Group, bit of a mouthful. I have no special qualifications to do this work other than the lived experience of diabetes. I'm joined on that committee by two others living with type 1 diabetes, who are Vicky Doyle and Kate Jazelska, and we're all on the Diabetes Ireland Advocacy Group, where Kate is actually the advocacy manager. Our presence at the committee's meetings, and indeed my presence here today, represents a growing awareness in our healthcare service that the client, for that is what we are, must be included as far as possible under the current structures in decision making. In other words, there's a movement towards speaking with rather than speaking at or for the person with a health condition or their carer. As diabetes advocates, we're able to try to influence both how decisions are made and which decisions are made. And whilst we sometimes regret the slow progress that we're making, we are at least a physical presence in the room. And we've been offered a voice and can speak truths grounded either in our own experience or in those reported to us to people who have power and influence. And if we weren't at the table, there would be much less chance to have that influence. First of all, I'd like to speak to anyone who's living with diabetes or caring for someone. I want to commend the documents being presented here today and the general transparency given to us by the publication of those documents online. There's a lot of information on the HSE website about our care, our rights, etc. And it's actually worth spending some time to investigate what's there. I also want to reassure you that the people who wrote the documents being presented today have your best interests at heart. They're published only after much thought and discussion, and they're no good lying in a drawer or on an unaccessed file on a computer. They need to be used. Diabetes can be a lonely place. We're continuously responsible for balancing our glucose levels. It's often challenging and we can't run to the GP all the time. So having that trusted material to hand is invaluable. I've used sick day leaflets in the past and I found them both informative and reassuring for me and the person who was caring for me. By being aware of them and using them, we may save ourselves that GP visit or worse, may mind ourselves just that bit better and improve our health outcomes for the future. Moving on, the transition to adult services is a challenging time for all involved, as is the diagnosis of diabetes during pregnancy. Both are very much in the forefront of the minds of your advocates because we know about and often highlight the difficulties arising in those services. The pregnancy model of care and the other documents launched today are your roadmaps too. Please use them to the full. And if those roadmaps don't match your reality as a service user, please speak out, advocate for yourselves, write to the clinical committee, contact Diabetes Ireland, maybe even join. Speak to your public representatives because advocacy is a proven effective way to move our story of people living with diabetes forward. Now to the HCPs. I want to commend to you the new pregnancy model of care, the leaflet on titration of insulin, and the plan for the prevention of diabetes report, which are being published, and urge that you read them carefully. The plan for prevention is going to be particularly important going forward in improving the health outcomes for our community and reducing the burden of complications in the future. The models of care and the prevention plan represent a new way of thinking about the person sitting in front of you. In the prevention piece, you are trying to intervene before the crisis has happened. You are encouraging the person to be proactive about their health rather than waiting for the crisis. This may involve discussing some tricky subjects like weight and eating and exercise habits. The new models demand a more collaborative approach towards the person living with diabetes, and it may take a while to accustom yourselves to it because of what it demands. It also requires the person with or in danger of developing diabetes to accept the challenge and make use of the services on offer. Collaboration needs more than one input. This brings me nicely to the Language Matters document. In another life, I was a teacher, and I never tire of telling people that you can't imagine how straightforward the language of explanation should be to be effective and to reach people. Many of you were educated to a high level, and it must be extremely hard to put yourselves in reverse and use really clear, everyday, non-stigmatizing language, just as it can also be difficult in the middle of a busy day to give your full attention to the person rather than the computer, but you must. This is why any documentation on language and how it's used is vital to the new strategies in the models of care. Let me remind you of the criteria relating to the use of language which a patient should be meeting under the model of chronic care. The person should know about their condition, follow a treatment plan agreed with the HCP, actively share in decision-making with that HCP, know how to respond to any deterioration, and be able to communicate their needs and the emotional impact of living with that condition. For those needs to be met, the use of language by the healthcare professional and the education of the person about their condition really matters. To conclude, effective advocacy empowers individuals by giving them a voice and helping them assert their rights and actively take part in decision making. Access to resources, such have been published today, informs people and is part of ensuring timely and fair access to services, sometimes helping us to find our way around complicated health systems. Decision making, which includes the patient perspective, is more likely to be appropriate for us and efficient, leading to improved health outcomes and better quality of life. At its most successful, it can also raise awareness, influence policies, and sometimes change the way the system works. But this can only happen if people volunteer their time and lend their voice. Thank you for listening.
Valerie, that was an excellent overview. So thank you very much again for your words and for your commitment to collaborate on many of these documents. So thank you very much. As a patient advocate, you've been immense. I'd like to introduce now Ms. Liz Kirby to talk about the National Diabetes Prevention Programme report.
Good morning, everyone, and thank you, Professor O'Keefe. I'm really delighted to be here today to share the details with you of the new National Diabetes Prevention Programme for Ireland. In my presentation today, I'm going to share with you the information about who this programme is for, the design of the programme, and what participants who take part in the programme, what they will experience when they come to the programme. It's also an opportunity for us today to launch the evaluation of the pilot report, which took place on the during the period of June 2021 to September 2022. And I'll share some findings with you on the results of that online pilot. I'll also be telling you a little bit about some new initiatives for 2024. So the design of the programme is based on international best practice, based on the NICE guidelines and the ADA guidelines for self-management education and support and medical nutrition therapy. It's also modelled on the diabetes prevention programmes that are available internationally. So diabetes prevention is not new. Our colleagues in Finland have been delivering programmes like this since with over 20 years, and similar programmes are available in the USA, Canada, Australia and the UK. And our new Irish programme has been modelled on those, but has been adapted to meet the unique requirements of the Irish healthcare system. It's also been built on the experience of our colleagues working in the Discover Diabetes, which is the programme for type 2. And both programmes have a very defined curriculum and philosophy of care. And that philosophy really encompasses the philosophy of empowerment and of person-centred care, and enabling people to self-manage their own care. And my colleague Karen would speak more on this in her presentation on the type 2 programme. So this DPP was designed for online delivery due to the fact that it was designed during COVID-19, and it has been delivered by trained dietitians in the community specialist teams. So for people who come to the programme, it offers them an individualised dietitian-led initial assessment and medical nutrition therapy, and they leave that individual assessment then with their own care plan, which they then bring to their 12-month programme. The 12-month programme is offered online for 1.5 hours over 6 weekly sessions, and then it moves to monthly sessions so that people get that 12-month block of care. And it's aligned to the GP contract for high risk and opportunistic screening and early intervention. So in the curriculum itself, it covers knowledge essentially, so providing participants with knowledge under 4 core pillars and the best evidence around eating for health, moving for health, weight for health, and change for health. But central to that as well are the skills that enable people to make healthy choices and can problem solve and overcome the barriers that we know are very common for all of us who try to make some behaviour change. And throughout the programme, participants' confidence is built through person-centred discussion, through sharing of their experiences in that group setting, and through setting of realistic goals. And they have the ongoing support of their peers in the group and the healthcare professional in the group as well. So who's the programme for? So it's essentially for those who are at the highest risk of developing type 2 diabetes, and particularly those with a diagnosis of pre-diabetes. And that diagnosis is on the basis of a HbA1c of 42 to 47 millimoles per mole. We're delighted to say that it's free to all. So whether you have a GMS card, a GP visit card, a long-term illness card, or are a private patient, you can access the programme. Referral to the programme is through your GP, and you will be referred to the hub dietitian. And for GPs listening, if it's available in your area, you will find the diabetes prevention programme in the drop-down menu on your health link, or you may have other local arrangements for referral. And I guess what I really want to say to you all today is whether you're somebody with pre-diabetes or know somebody that has pre-diabetes, or you're a GP considering referring one of your patients, we want to just tell you that programs like this one really do make a difference. Internationally, we see a risk reduction of 58% at 1 year for people who take part in these programs. And that risk is sustained at 33% for up to 10 years after taking part in a program like this. And even for those who do progress to type 2 diabetes, that onset is delayed by 4 years, which is really significant. In terms of clinical outcomes, we've seen in the international programs weight loss of around 5% and 2 millimoles reduction in HbA1c for those that take part. And we also know that the more sessions you attend, the better your outcomes are. So the long programme of 12 months of care is really effective and helpful to people who take part. So this leads me then to the Irish setting, and against that backdrop of that international evidence, we were tasked to design, pilot and evaluate a diabetes prevention programme for Ireland. And this report that we're able to launch today outlines the aims and the objectives of that programme. It describes the programme design, the pilot design, and how we evaluated the process. And I'll be sharing with you some of the results in a moment. We learned lots of lessons along the way, and that has enabled us to make recommendations for scaling up of the programme now at a national level. So just to tell you a little bit about the pilot itself, we ran the pilot in 6 CHO areas, and we had 73 participants engaged in the pilot. Participants were eligible on the basis that their HbA1c was within that pre-diabetes range. And it was great to see that we had both an even mix between males and females attending the pilot. And we had people of all ages, young and old, participate, with the youngest being 35 and the oldest being 82, which really encouraged us to see that, you know, an online program was accessible and open to all. And in practice, I think what we found was that once people got some support with engaging in the online space, they were really happy to attend an online program. And the pilot was delivered by trained, experienced dietitian educators. So what did we evaluate? So we evaluated the pilot at baseline and at 12 months, and we measured attendance throughout the programme. We measured weight and BMI and HbA1c at the beginning and at the end of the programme. And we also carried out a service user evaluation, asking the participants to complete an online survey, again at the beginning and at the end of the programme. And that survey asked people about their knowledge and their skills and their confidence around diabetes risk and the lifestyle behaviours that they need to engage in to reduce that risk. And at 12 months, we asked a further few questions around the satisfaction with the overall programme. So just to share with you some of the outcomes from that pilot phase, we were really delighted to see some very positive clinical findings at year 1. And really the findings mirrored much of the international larger scale studies. We saw a 2.29% reduction in HbA1c. And in fact, half of the group actually returned their glycemia or their blood glucose levels to the normal range by the end of the 1-year programme. By the end of the first year as well, 73% of the group had lost weight, and that weight loss was in the range of 5.5%, which again was very similar to the international studies. And even in those who did not lose weight, we saw weight stabilization and very few gained weight, and that weight was modest, with no more than 2 kilograms of weight gain in the group that stayed with the programme, which is very encouraging for us. As well as the clinical findings, we also saw some really positive findings in terms of the participation levels and the experience of those that took part. We had very high levels of engagement with the programme, with 92% attending at least one session of the group programmes and 73% attending the first 6 sessions, with 72% staying with us for at least half of the sessions and 66% completing the programme. So those levels of participation are really quite high and very encouraging for us to move the programme now to a larger scale implementation. What people said about the programme was that they found it increased their knowledge of their diabetes risk, and it improved their skills at shopping and planning for healthy food. And this one was up particularly high. People also said that it improved their confidence with engaging online and with making healthy food choices. And they also said that it helped them to achieve their goals around physical activity and their weight. And they described having very high levels of satisfaction with the programme, with 95% saying they found the course to be excellent or very good. So it is against that backdrop, I guess, that we have now the confidence to scale up the programme so that it'll be accessible to all in CHO4 in 2024 across all CHO areas. Some other developments for 2024 will be that we aim to adapt the curriculum for in-person or face-to-face groups for this year, so that it enables people to have a choice to join a programme either in the online space from the comfort of their own home or close to their own home in a hub near them in a small group. We're also adapting the curriculum this year for women post-gestational diabetes because of the particular high risk of this group. And we want to offer a programme that is uniquely adapted to meet the needs of this particular group. Towards the end of 2023, we were also very fortunate to achieve CESMET accreditation. CESMET is the Quality Institute for Self-Management Education and Training. And this has enabled us, and I would like to thank my team for all the hard work to enable this to be achieved last year. And what that means for 2024 is that we will now be moving to support all of our trained educators to progress their own individual journey in this CESMET accreditation process. So there's lots happening for 2024, and we're really looking forward to being able to offer this diabetes prevention programme to all. So I'd just like to conclude by thanking everyone, and in particular, I'd like to thank a small group of people who started out in that very first pilot with me in July 2021, and all of my HSE colleagues and academic partners and collaborators who enabled this project to be successful. The full report will be on the HSE land for my HSE colleagues, and I'd encourage everyone to visit the HSE website, where you'll find some more information about the programme and how to access it. Thank you all.
Great, fantastic work, Liz. Thank you for sharing it with us. I'd like to hand you over now to Dr. Karen Harrington, who'll speak about the Discover programme.
Good morning, everyone. Can you see the slides okay?
That's perfect, Karen. Thank you.
Great. Thank you very much, and thank you, Professor O'Keefe. Good morning, and I'm delighted to share details of the Discover Diabetes Type 2 programme, our group diabetes education and support programme for people living with type 2 diabetes. Now, for those of you who are living with the condition here with us this morning, you may recall your head being full of questions when you were advised of your diagnosis, such as, what does this mean? What can I eat? How is it going to affect my health? It can be a time of shock, confusion and fear for many, we know. And the programme is termed self-management because when treating type 2 diabetes, for those of you living with the condition, you yourself are actually providing at least 95% of your own care in partnership with your GP and your diabetes care team. You're the most important person treating type 2 diabetes, so you need access to a supportive, non-judgmental space and time to learn about the condition. Essentially, you're self-caring or self-managing the condition. So the good news is your GP can refer you to Discover, our community intervention that offers you a place to get all your questions answered. And this is offered in the Hub Specialist Diabetes teams. With the support of the community diabetes dietitian and others living with the condition, you'll discover insights. You'll get to identify the self-care options that you would like to consider to treat your diabetes, hence the name Discover. So I'm going to share with you how we created. Sorry, I'm just trying to move forward the slide, but it's not going forward for me.
Karen, if you come down to the left-hand corner, hopefully some, yeah, there we go.
Lovely.
Thank you.
Thank you. So I'm going to share how we created and tested Discover and its positive impact. The vision was a 1-year program, a 4-session course ran weekly, 2.5-hour sessions, with follow-up at 6 months in year 1, delivered by one community dietitian. And this is one of our groups in CHO7. The programme content was guided by the latest evidence and international standards on type 2 diabetes, medical nutrition therapy and self-management education and support, which we documented in care guidelines. It was also guided by our philosophy of care, where we described how we are going to support people to take an active role in their own self-care. Our philosophy was underpinned by 9 components and the guidance of international experts work in particular on person-centered care, empowerment, behaviour change and emotional support that we've heard many times this morning being so important and stressed by Valerie. We're grateful to those who've generously shared their work shown here, which has guided us hugely in the success of this work. The Discover programme focuses on making sure that people are fully informed, and these are samples from our participant handbook for you to see the client experience. At the first session, people learn what the condition is and the seriousness of the condition, and also the possible health problems if it's not looked after, but very importantly, how treatable type 2 diabetes is. We support people to take ownership of their own diabetes. People learn the value of knowing and understanding one's health results. HbA1c, blood pressure and cholesterol. One's ABCs is what we call them to make it easy. As a person living with type 2 diabetes, as you are self-managing the diabetes the majority of the time, it's really important that you get a chance to understand how you're really doing and where it might benefit you to improve. People learn about their own My Diabetes health results, and this has helped people to gain confidence when discussing diabetes with your GP and others. These are further pages from our participant handbook, and people are informed of treatment as 10 components to make it easier to understand. And there's a major focus on minding your mind, regular checkups, and taking an active role in your care. There's a big focus on making changes, inviting people to make personal plans for change, as seen here on the right, setting goals every week and using the course as a chance to practice making these changes in between weeks. And the importance of minding our mind is threaded through every session, conveying hope as we work through the topics, acknowledging that it can be hard work looking after diabetes sometimes while we're trying to live our life. Self-monitoring and support are key behaviour change strategies that are integrated into the course. And we're delighted that Discover is fully integrated with all HSE messages, services and supports, which makes it much easier for the public to navigate the HSE services and for healthcare professionals. We evaluated Discover with an audit on 12 courses, starting in 2019 and finishing in 2020. 12 core courses of 4 sessions were evaluated at baseline and week 4 with great engagement. Participants were offered a chance to return at 6 months for follow-up and evaluated further. And at year 1, we checked in. We had a very comprehensive audit, and the next slides are going to share a snapshot of our results, which will be presented in our report. So 180 people with type 2 diabetes participated, and at baseline, people aged 30s to mid-80s attended, though the mean was 63. 64% had diabetes for more than 12 months at that time, and 77% were using diabetes medication in addition to diet and lifestyle for their treatment, which could explain why more than half had HbA1c within target. That's the clinical marker for monitoring diabetes that we mentioned earlier. And 2/3 were living with obesity. Our analysis of the completers showed really high levels of engagement seen in the green circles. Essentially, our service user evaluations revealed that people went on journeys of self-care, learning about their personal health results, which empowered them to make changes through their behaviours during the year, resulting in statistically significant clinical improvements. Excuse me, sorry, So there were 4 key findings. There were 4 key findings for HbA1c, weight and body mass index shown here on the right. They all improved. The average change across time from baseline was significant reductions, and the percentage of people in the higher risk categories reduced over time. And the people with higher baseline values benefited the most, revealing greatest reduction from baseline at all follow-up time points. And at all follow-up, more individuals were improving their outcomes than disimproving them, which was wonderful news. Forgive the next busy slides, but it does help to share Discover's impact, the reductions in HbA1c, weight and BMI. In particular, looking at the blue writing, of particular interest is when we looked at those with a HbA1c above target at baseline, we saw even greater reductions in their average, 9.5 at 6 months and 7.4 at year 1. And when we looked at individuals with HbA1c above target, more than 2/3 reduced their HbA1c by 6 months and again at year 1, with approximately half of them reducing it by as much as 11 millimoles or more at both 6 months and year 1. And this is a reduction that's been shown in a landmark UK prospective diabetes study to reduce the risk of morbidity and mortality, and is well comparable to diabetes medication intended effects. In terms of body weight, the average change at week 4 was a 3.5 kilo reduction, which was approximately sustained at 6 months and year 1. And again, we found more individuals reduced their body weight than increased it at follow-up, approximately 2/3 of the group. And in those who lost weight, we observed a trend of greater weight loss over time. And the BMI results, the body mass index, also reflect these improvements. We broke new ground addressing the psychological aspects of living with diabetes, which is recommended internationally because it affects emotional health and people's ability to manage diabetes. And we were guided by the work of Dr. Christelle Hendricks we mentioned earlier. We used a 20-question validated questionnaire called PAID-20, and this examines problem areas in diabetes that are being experienced by people. The questionnaire generates a PAID score for each person, and scores of 40 or more indicate severe diabetes distress. At baseline, most people fell in the low to moderate diabetes distress category, but scores were highly variable as seen by the range. 27% fell in the severe diabetes distress category. And we learned people's top concerns, with the top 5 being shown on the left. People were worried about the future and the possibility of serious complications. They felt constantly concerned about food, felt guilty or anxious when they were off track with their diabetes management, felt deprived regarding food, which is something we all have to do every day. And they felt that not having clear goals was also a concern. And Discover participation successfully addressed these concerns. Seen in the top row, the average paid scores significantly reduced at week 4 and were sustained at 6 months compared to baseline. And in the bottom row, the 27% who had severe diabetes distress at baseline, this reduced to 14% at week 4 and was sustained at 6 months. So Discover was a huge support to people coping with diabetes. We value the voice of the person living with diabetes in our development journey, and we completed comprehensive service user evaluations, which has been invaluable. And this is data from 129 people at week 4, which reveals that there was overwhelmingly strong agreement that people enhanced their knowledge and skills, their confidence, their awareness of the seriousness of diabetes and how treatable it was, with a very positive experience. They were empowered to take an active role in their self-management, and they shared changes they made and others they would like to change in the qualitative data that they shared with us, which resulted in the improvements that we've discussed. And here are some of the comments from the week 4 service user evaluations. Glancing through them on the left, you see that the course was exactly what people wanted. They loved learning about their health results and being in a group together. They moved from a place of fear and confusion to one of actively self-managing, and they highly praised our HSE dietitians. So we demonstrated that Discover was an effective programme as part of the type 2 diabetes care journey. And this enabled us to develop a plan for national scale-up and rollout. And I'm delighted to share that we're running in 8 CHO areas. Having our own HSE programme supported us to move online when we were challenged by COVID. And the Integrated Care Programme Diabetes Dietitians and myself here, in 2020, we were tasked to transform the existing Discover for online delivery, to work in a very new HSE digital environment, and to create a training package to train dietitians, but now online. And we did it. We worked together online and we trained over 100 dietitians online by May of 23. And in May of 21, we had our online product, a 6-session course. By March of last year, we delivered 88 online courses, registered almost 1,000 with 4 and 5 attending, of all ages, both men and women. So when people register, they tend to stay. And by the end of last year, we had ran 114 online courses for people with type 2 diabetes. And we continue training new educators online in the in-person and online course. And we're currently training another 20 this week. We evaluated the online course. Excuse me, sorry, I didn't move the slides forward there. Forgive me, Jean, if I'll ask your help if I missed that. We evaluated the online course as we went, addressing attendance and service user feedback, and we were blown away by people's engagement and their experience shown here on the right. And people's comments shared again how they felt that the course was giving them the power to make changes. They were gaining confidence and understanding their health checks and their health results and how to protect their health. So this slide here is showing that, again, having our own programme enabled us to partner with our colleagues in HC Communications, and we recruited a diabetes dietitian to help us develop a number of digital supports. I'll just draw your attention to our HC website, which is a go-to place where you will get lots of information and also further signposting, hc.ie/diabetes, and our recently launched diabetes email programme, which is a 1-year programme that people can register for via the HSE. So we're excited to expand the range of options to help connect people to trusted information to help care for their diabetes and access services. And finally, I would like to sum up by just sharing that our Discover Type 2 Diabetes programme is actually available to all, whether you're a private patient, a client using a GMS card or a GP visit card, whether you have a new diagnosis of diabetes or an existing diagnosis. Referral is via your GP, and self-referral and further information is available through the HSE website. And there is a free participant handbook provided to everyone who attends. Our healthy eating booklet has now been expanded to be available in 13 languages. And here are some of the participants from our CHO and CHO 5 and 7 area that have been participating in programs with their local diabetes dietitians. And finally, I would like to acknowledge a wide variety of people that have been involved. People living with diabetes and their families have given us a huge amount of their time guiding us in our service development, our HSE colleagues, the development team, dietitians in CHO 4 and 5, international leaders and academic partners. And I would personally like to thank the community dietitians who work with me. We work together across the entire HSE, and these are a hugely dedicated bunch of people who put the person front and centre of everything they do as we develop care and accredited programs for people with type 2 diabetes. Thank you.
Fantastic. Thanks, Dr. Karen Harrington. A brilliant program that I've seen firsthand myself on how knowledge is power and how education empowers people. So Great work, well done. I'd like now to introduce my colleague, Professor Sean Dineen, who was a previous National Clinical Lead for Diabetes, a clinical innovator in diabetes across Ireland, who continues his commitment to diabetes care by sharing now today the results of the transition survey. Over to you, Prof. Dineen.
Thanks, Derek, and thanks very much for the invitation, and congrats to Derek and Dervla and everybody involved in this outstanding webinar. So as Prof. O'Keefe mentioned, I handed over national lead role to him. At that time, there were, I would say, two major unfinished symphonies, if you will. One was delivering a national diabetes registry for Ireland. That's still work in progress. It was really encouraging to hear the Minister for Health endorsing the importance of this in his address earlier in this webinar. The other unfinished piece of work I'm going to tell you about now, without any slides, and it's a report from a survey looking at the transition of care of adolescents and young adults with type 1 diabetes from pediatric to adult outpatient services. So living with type 1 diabetes is not easy at any age, but it is particularly challenging in the adolescent and young adult age range, because at that time in the life cycle, people are dealing with an awful lot of change in terms of their educational facilities. They're often moving from home, taking up employment, experimenting as you do in that age range, and diabetes can get in the way. So the transition of care, it's really important for us as healthcare professionals to manage this well. And so this study, which was led by Dr. Maura O'Donnell, a colleague of mine in the University of Galway, was what's called a mixed method study. So Maura surveyed all of the hospitals involved in receiving adolescents or young adults from pediatrics and followed up that survey with interviews. And the 18 of the eligible outpatient services, adult services, completed. That's a 62% response rate, and all of them completed the interview. So what were the findings? Well, I'm just going to give you some highlights from the survey. The standalone children's hospitals, mainly in Dublin, as you know, transition usually happens at about 16 years of age, whereas from pediatric outpatient services that are co-located, more commonly, transition occurs around the time of Leaving Cert, after the Leaving Cert exam, around 17 or 18 years of age. Over half of adult services reported having joint face-to-face transition clinics with their pediatric colleagues. So the adult team would join with the pediatric team and see the young person together. Referral letters from Maura's review of the international literature were somewhat unstructured. They were traditional, like traditional clinic letters, but did not include, for example, a psychological summary of the young person's readiness for transition, their self-care ability, the preferences for parent or carer involvement in their care. These things are important and were identified as deficient in some of the transfer letters. Maura also looked at the frequency of visits once the young person had transitioned and the interval between the transition letter being written and the first visit in the adult service. The percentage of transitioning adolescents, young adults who were using either flash or continuous glucose monitoring ranged from 42 to 100%, which is really striking. The percentage of adolescents or young adults using insulin pumps at the time of transition ranged from 12 to 88%, which I think is also striking. And as we heard earlier from Kira and our colleagues working in diabetes and pregnancy, the landscape here is being transformed at the moment around diabetes technology. One reason for undertaking the survey was an impression, which was supported by the data that we generated, that not all adult services accepting adolescents or young adults were properly skilled to manage pump therapy. And this is something that I think has come out of the survey as a need to improve in certain services. So the recommendations were that a more structured approach to transition of care should be delivered, and Dr. Kira Martin, who's the National Clinical Advisor and Group Lead for Children and Young People, I know currently her team, Dr. Martin and her team are working on a framework for transitions, and this is an opportunity for us to liaise with them and improve transition for our adolescents. Each pediatric service should have a defined pathway to the adult service, and that should include a more person-centered, structured referral letter. Non-attendance at clinic is a feature of diabetes care in this age group, and therefore we felt in writing the report that further exploration of alternative methods of engaging with young adults should be looked into, and I would signpost you to our D1 Now study, as we call it, which is looking at this issue of how do we improve the delivery of clinic-based care for 18 to 25-year-olds in our adult services. We also recommended that the adult centres receiving the care of young people should ensure that they can meet the clinical needs of this cohort, particularly in the area of diabetes technology. And finally, when young adults are admitted to hospital, and I noticed a question in the Q&A around this issue of sick day rules for users of pump technology. But we have an obligation, I think, as specialists in diabetes care to provide basic training in pump therapy and CGM, not just for our own staff, but for the wider non-specialist hospital staff who look after these patients during their admissions. So thank you for your attention, and well done again to the team for an outstanding webinar.
Thank you very much, Prof. Deneen. Great results from that transition survey that will feed into future care plans, policy, and the way we operate diabetes services in Ireland. I'd like to introduce now Dr. Kathy Breen, the National Dietetic Lead from the National Clinical Programme, and Ms. Sinead Powell from Diabetes Ireland.
Thanks very much, Derek. And maybe before we start, I might just thank both yourself and Minister Donnelly for acknowledging and recognising the work that we in Diabetes Ireland do. We're such a small team, so we appreciate that acknowledgement today. Now, my share, why have I lost my screen? Here. Kathy, I'm not getting an option with my, if that's okay for you to share. I'm sorry, it just didn't pop up there. For some reason, my options look different to usual. Yeah.
Kathy, if you can unmute yourself for a moment. If you're unable to share, let me know and I will share for you.
Yeah, I'll share.
Yes. Thanks for that. So we're delighted. My name is Sinead Powell, and I'm going to co-present with Kathy Breen today on behalf of the National Working Group for Language Matters document. And I suppose all of the documents today have been developed by the National Clinical Programme, and this document is funded and supported by the National Clinical Programme. But the working group involves a bigger collaboration. So people with lived experience of type 1 and type 2 diabetes, academics, healthcare professionals, and when we get slides, all of those will be, all the logos will be at the bottom of those. So just to, I suppose, to say the importance of a document like this is that language is so important, whether it be written or verbal, in how we communicate to and about people with diabetes. So the plan for just this very short session is maybe just to outline how we came together as a group, why the language matters, the evidence that supports that. I'll pass on to Kathy then, and she's going to cover where to find the document. There will be links as to how to access it, and then the general recommendations and examples that are made through the document. So we formed around this time last year, and just to acknowledge Grania Flynn, who is a campaigner and advocate for people with diabetes and who has lived with type 1 diabetes for a number of years. She reached out to a few stakeholders, and the group grew to over 10 people. And really what we decided to focus on as an initial piece of work was to produce a guide aimed at the general public and the media as to how we talk about and to people with diabetes. So it was developed as a support and maybe a first step of how we work on language matters in Ireland. Now, language matters, it's not a new concept. It's been around and referenced in an earlier presentation by Karen Harrington, the work that a group in Australia started in 2011. And if you visit languagemattersdiabetes.com, you will see it's a global movement with lots of positions, papers and statements and guides from lots of different countries around the world. So what we've produced isn't reinventing the wheel. What we wanted to gain, I suppose, by doing this work was to have something that was visually appealing, short, to the point, that would grab people's attention so we could spread the word. I see there's over 400 people on this session. Some of you may live with type 1, type 2 diabetes, and we probably have a huge number of healthcare professionals. So it's really while you might know about the Diabetes Language Matters movement, take this opportunity to share this guide wherever possible after this session. And just moving on then, Kathy. So yeah, these are the logos of everyone I've mentioned already, and they're also on the final slide. But a thank you to everybody. And I think it's fair to say that we're all delighted to work and to be a part of such a significant work for language and language matters in Ireland. So moving on to then, well, what's the evidence and why are we so passionate about this piece? Emotional health has been discussed on a few occasions, but there is a lot of clinical evidence to say that the words we use at diagnosis, in the media, in general conversation with family members and friends, can have a huge and lasting impact on the emotional well-being. And that in turn then can impact on people's adherence to medications, to attendance at appointment. So just to be more conscious that your words can heal and harm. So a person could feel very much empowered and supported, or they could find themselves in a negative space where they feel maybe judged, belittled, undervalued, blamed, and misunderstood. I'm going to just include a couple of the quotes that we have in the Language Matters Guide for Ireland, where a person living with gestational diabetes reported that someone had said to them, "You really should be trying to lose weight. Are you not going to put your baby at risk?" I'm sure there's many health professionals on this webinar who've heard so many times, and we in Diabetes Ireland are continually hearing where people feel judged, that somehow they think that because other people think that because they have a diagnosis of either type 1 or type 2 diabetes, gestational diabetes, that they feel entitled to comment on their food choices, and that can sit with them then with an element of guilt, blame and judgment, resulting with an awful lot of people not wanting to share that they have a diagnosis of diabetes. Saying that also, there's a lot of people that may not do this intentionally, might not even be aware of their language. So just move on to the evidence, and I'll hand over to Kathy then. So the evidence is very clear around this, that language that is used in the media, and Kathy will show examples of that, can be very stigmatizing. I mentioned already that at diagnosis, it can have a lasting impact on how the person feels. There's a huge amount of information online which is confusing, inaccurate, unrealistic, and harmful, especially in the areas of food and appropriate treatments and food choices. And this affects people's self-management. And I mentioned already that they can feel supported or misunderstood. And so it's to take that judgment piece away from it if we can. The unhelpful comments, jokes and jibes linked to diabetes result in diabetes distress, depression and lowered self-esteem. So it's to try and reduce all this, and that's why we're delighted to be launching this document today, to reduce those feelings of isolation and loneliness that research has showed that people really struggle with because of the use of language. Now I'll hand over to Kathy, and thank you.
Super, thanks very much, Sinead, for the background to the project. So the document is now available at diabetes.ie/talking about diabetes language matters. And going forward, we'll be promoting it on social media with the hashtags diabetes awareness and hashtag language matters. So when we're recommending this, what do we mean by language matters? So I suppose very broadly, it's talking about diabetes in a way that is person-centered, language that is neutral and non-judgmental, that recognizes the strengths of the person living with diabetes, is respectful, inclusive, and collaborative. So I'll give you just some examples from the document. We want to move away, I suppose, from words with negative connotations like suffering from diabetes to a person living with diabetes. We want to avoid judgmental language like compliance, and use more person-centered language, like the person is engaged or involved. Talking about glucose rather than sugar levels, which I suppose can really suggest that the onerous task of self-management and its complexities can be reduced to simplistic nutrients. We want people to avoid, I suppose, hyperbole and dramatic language, and talking neutrally about diabetes and its health complications that can occur. And I suppose acknowledging very broadly that diabetes is not something that is easily controlled. It is instead a chronic condition that is primarily self-managed. And if we have anybody here today from media, or any of you people with lived experience of diabetes or healthcare professionals who are engaging with media, we have given some suggestions for using more helpful headlines in media when talking about diabetes. And so my final slide, I suppose, is to cover some thank yous. In particular, we'd like to thank Dr. Sarah O'Brien and Ms. Mary Gleeson from the ICPCD office, who supported the project with funding for finalising the document. Ms. Dervla Kennedy for her support in the project as well, and Dr. Karen Harrington from the SMES office for her input. I'd especially like to thank Grania Flynn from Thrive-A-Betes and Sinead from Diabetes Ireland, who, as you've heard, began this project, and myself and Joanne Lowe were absolutely delighted to be invited to collaborate from the National Diabetes Programme. And it's been a really wonderful part of the work of the programme, I think, across the last year. And then we have all the wider members of the working group from academia and lived experience, so Susie Burney from ICPO, and Marie Craven from University of Limerick, Sonia Deshane and Amy McInerney from University College Dublin, Tomas Griffin and Emer Morrissey from University of Galway, and Cameron Crean and Michelle Lowry with lived experience. And the working group, just to flag to you, is now working on collecting Irish data on the impact of language in diabetes. So we'd really encourage people to download the document, share it, and use the guidance, which we hope will meaningfully enhance and improve all our conversations when we're talking about diabetes. Thank you.
Great, thank you, Sinead Powell and Dr. Kathy Breen, for your great work and leadership on a really important document. I think it's going to change the way that care is, interacted with patients going forward. So thank you for that. So I'd like just to finish now, maybe with an update of what the National Clinical Program of Diabetes has been doing in the last year or so. So I'm just going to share my screen. Hopefully you can see that there now. So as I said, I'm the clinical lead for the National Diabetes Program in Ireland, and I work with a great team of people. The program manager, Dervla Kennedy. We have a national clinical lead of dietetics who you've just met there, Dr. Kathy Breen. National lead of nursing, Ms. Joanne Lowe, who you met earlier, and also Yvonne Maloney, AMP. And we also have a national clinical lead for podiatry with Assumpta Coyle, and a national ICGP lead, which was Dr. Lisa Devine, who you also met earlier. So a full MDT team that meets regularly to discuss active issues in diabetes, as well as collaborating across a range of projects and documentations that you've seen here today, some of them listed. And that's really important to recognize that what we do inside the HSE is very collaborative. So we work with a lot of stakeholders and shareholders, as you've mentioned there, Diabetes Ireland, the great team led by Kieran O'Leary and so on. Grania Flynn does great work with Thrive-A-Betes, and then individual patients who are part of our diabetes working group, which involves over 30 people, both living with diabetes and then also the clinicians and policymakers involved in their care. So it's really important to acknowledge that this is a team sport, and everything we talk about is related to that. So just to say what the National Clinical Programme does, so we've been set up since 2010. There's been many clinical leads over the years. I took over in January of 2023, so just over a year ago. And one of the first things I wanted to do was to visit every site in Ireland that delivers diabetes care. So it's really important, it's one thing to write it in a document, but it's really important to see where the rubber meets the road. So there's over 30 sites in Ireland that deliver diabetes care through hospitals and hubs. You've heard about the Enhanced Community Care Programme from our NCAGL, Dr. Sarah O'Brien, and that's a really important thing that's happened in Irish healthcare recently for the care of people with type 2 diabetes. So over last year, we visited all those sites across Ireland, and obviously where you get your care is very personal to you appropriately, but you have to remember, I guess, that it's a national picture of what we're focused on in our strategy and our operationalization of the documents that you saw here today. So whether you get your care in Letterkenny or in Waterford or in Limerick or in Galway, it's really important that the same services are offered to everyone appropriately. And when you actually meet the different teams delivering those cares, there's inherent problems locally with, both physical infrastructure, staffing, recruitment, IT issues, and so on. And it's important for us as the representatives of all those people to understand what's working and what's not working so we can advocate for improvement. So that was a really important thing to do. So as well as those 30 visits that we did last year, a really important reason why I took on the job of national lead was to advocate for continuous glucose monitoring access for all people with type 1 diabetes. So you might know that up to 2022, it was only available for people under the age of 21 years of age as part of their routine care. So I'm delighted that because of the work we've done with the HICWA HTA and engaging with a lot of stakeholders throughout the HSE, we've managed to secure that. So now all patients in Ireland with type 1 diabetes has access to CGM. The other really important work we've been doing with the chair, Kevin Moore, for the type 1 guidelines and Dr. Owen Noctor for the type 2 guidelines is updating the guidelines for diabetes in Ireland. With Dr. Kevin Moore, it's the NCEC guidelines to harmonise us with the NICE guidelines in the UK to ensure that our guidelines are up to date. The most recent guidelines were 2018. Because of the pandemic, the natural cycle didn't happen after that, so it's happened now. We'll be publishing them shortly. And that's really important work for people living with type 1 diabetes. And then for the type 2 model of care that Dr. Owen Noctor has led out on, again, a very collaborative process with over 30 stakeholders involved. Those model of care will be published in the next month or two. So really important work because that'll serve as the cornerstone for care of people with diabetes in Ireland, both type 1 and type 2. You've seen today the great work that's been done with the model of care with people with diabetes and pregnancy and the other insulin titration documentation and so on that's been published today. Indeed, the great work that's been done with diabetes prevention and then also education around diabetes education if you do have diabetes. I think that 360-degree thinking is really important in the way that we address the tsunami of a chronic disease that diabetes is. You might have seen the latest figures suggest that about 600 million people on planet Earth have diabetes at the moment, and by 2050, it'll be 1.3 billion. So that's a huge number of people suffering with a chronic disease such as diabetes. So it's something that we do need to prepare for in our strategy. And it was very heartening for the minister to speak about a strategy for diabetes, because that's going to be really important. The other thing we've been doing is, as I mentioned, is supporting the rollout of the different services across the 30 hubs in Ireland. We've also supported our colleagues in the National Institute of Medicines to produce the latest guidelines of which pharmaceutical medications are appropriate in diabetes care. We've worked very collaboratively with patient advocacy groups, as I mentioned, Kieran O'Leary, Kate Kajowski, Sinead Powell in Diabetes Ireland, Grania Flynn in Diabetes, across the HSE itself, both clinicians and policymakers, and then also people living with diabetes. It's really important to have that kind of joined up approach if you want to have a document that reflects the real lived experience of diabetes and one that has the maximum chance of success. And as we've heard, progress can be slow when you put together documents, because you do have so many stakeholders involved. It's really important to hear everyone's opinion and get their input into the finalized document. So it's great to be launching the diabetes and pregnancy model of care today. And then hopefully other ones will be launching in the next month or two. We've done a lot of work with public engagement, such as this session today, to invite the general public to this, as well as people with diabetes and clinicians, so they know what the program is doing. I think that's really important. We ran another session last year. That's really important to have that open communication of what the program is doing, so you can see both the complexity of what we're doing, but also the collaborative nature and the fact that progress is being made across many domains. I'd like to also acknowledge the work that Dr. Claire Buckley and Professor Sean Deneen have been doing in continuing to advocate for the registry, something that we're very passionate about as well in the National Clinical Programme. With a disease such as diabetes, it's really important to be able to know how many patients we actually do have in Ireland with diabetes. At the moment, we use best guesses based on the academic literature to say that about 6% of the population probably has it, based on other countries' registries. So I think that's really important, that in Ireland we strive to build a complete registry of patients with diabetes, so that we can both tailor our services appropriately and also monitor the effects of which interventions we do. The other thing that we did, and I'd like to thank Kathy Breen for her leadership on this, is map out the delta, the improvement in services that have been delivered around Daphne in Ireland. So back in 2018, 6 centres in Ireland had Daphne, structured management education for type 1 diabetes. And now there's over 20 sites in public hospitals across Ireland. That's a tremendous improvement in access to quality healthcare education for patients. And then just again, to summarise, we've worked again with the policymakers, the government. We've worked with a cross-parliamentary group. We're meeting them again this week to tell them, what's going well and what's not working. And Cormac Devlin has done a great job chairing that committee. It is very important to collaborate and not just be in our little islands across the clinical world, the policy world, the patient world. We all have to work together to achieve, progress. And I think we've done that in the last 12 years or 13 years of the National Clinical Programme, and what we'll continue to do going forward. And I'd like to thank all of you for attending the webinar today. It's great to see such interest in diabetes care in Ireland. Over 400 people came this morning and stayed with us for the full 2 hours. And just to finish, I'd like to thank especially Ms. Dervla Kennedy, who's our program manager, who does stellar work for the program. I think everyone who works on the National Clinical Programme and beyond would acknowledge that. So I'd like to take a special mention to thank Dervla for her work. So thanks to everyone for attending today. I know there's been several questions put in the chat. So what we're going to do is we're going to answer all those questions individually, and we're going to circulate a Q&A sheet to all the participants of the webinar this morning, so that you'll have your questions answered. So thanks very much for your time and your attendance. We're delighted to have you join us here this morning, and special thanks to both our NCAGL, Dr. Sarah O'Brien, and indeed her team led by Ray Gleeson, and also the Minister of Health, Mr. Stephen Donnelly, for his attendance today. So thank you very much.